Understanding and being able to differentiate between a upper and lower motor neuron lesion is a vital skill to learn as a physician and very important for your MRCP Part 1 and Part 2 and also for your neurology station and PACES. So let's get into it. Let's start by having a look at the motor tract. So the motor or descending tract is made up of the corticospinal or pyramidal tract, the lateral and anterior branches, and the extrapyramidal tract. Now, we'll follow the lateral corticospinal tract, which makes up 90% of the tract and is responsible for the majority of the voluntary movement in the body. It starts with initiation of a motor impulse at the prefrontal cortex in the brain, and it goes down to the medulla, where it decussates at the medulla in the pyramids and goes down the contralateral side of the spinal cord. So the left side of the brain controls the movement of the right side of the body. At the level of the spinal cord, the fibers synapse into a lower motor neuron, which goes from the anterior horn of the spinal cord to the effector muscle. Now, any lesions above this synapse causes an upper motor neuron lesion, and any lesion below the synapse causes a lower motor neuron lesion. So lesions affecting the brain and the spinal cord up to the synapse at the level of the spinal cord is upper motor neuron, and below that is lower motor neuron. So what are the signs of upper motor neuron lesion? On examination, we find hyperreflexia, hypertonia, clonus, upgoing plantars, and weakness. Now, comparing that to a lower motor neuron lesion, you get hyporeflexia, hypotonia, downgoing plantars, and you usually get more weakness and muscle wasting. Now, the causes of upper and lower motor neurons are very important, and the best way to remember it is to categorize, especially for your PACES. When you're asked, when you have a case that you think, all right, this is an upper motor neuron lesion, how do you mention the causes? There's so many different causes for an upper motor neuron lesion. It shows great organizational skill, being able to just make 3 simple categories. Now, with upper and lower motor neuron lesions, I categorize by time, which it categorizes it really well in your head as well. So let's categorize it according to time, with acute, happening over hours and days. These are your strokes, for example, cerebral infarcts and hemorrhages, spinal cord traumas after, for example, God forbid, a road traffic accident, or in the setting of an acute transverse myelitis. Now, subacute, which present in days to weeks, are demyelinating conditions such as multiple sclerosis, so relapsing remitting, spinal cord compression, so tumors or disc prolapses, infections, abscesses, encephalitis, or CNS infections such as TB meningitis or HIV myelopathies. Okay? So you can see how you can make these categories and mention 2 or 3 headers per category. Even if you say just 1 or 2 header per category, it just shows very, very good organizational skills. So let's carry on. Chronic, happening over months to years. These are your hereditary causes that have been present from birth, such as hereditary spastic paraplegia or cerebral palsies, which show a static upper motor neuron lesion, or chronic cervical spondylotic myelopathies. Now, with the lower motor neuron lesion causes, we'll do the same. Acute causes, happening over hours to days, are GBS, which is a usually bilateral ascending paralysis, poliomyelitis, or intraviral infections, toxic neuropathies, such as heavy metal poisonings or organophosphates. Subacute, happening over days to weeks, our most important differential is CIDP, chronic inflammatory demyelinating polyneuropathy. which is a demyelinating condition, but has predominantly lower motor signs, lead poisoning or Lyme disease neuropathy, and chronic causes, which is of the most common causes of peripheral neuropathy and lower motor neuron lesions, are causes such as diabetes and alcohol, and or genetic causes such as Charcot-Marie tooth. Post-polio syndrome leads to a chronic weakness and post-polio weakness and wasting in the muscles, and atrophies such as spinal muscular atrophy. So this is again a general overview. All you need for your PACES exam, if you need to give a few differentials, categorize acute, subacute, chronic, and give one or two examples in each. Generally speaking, think of where the lesion is. Anything, as we said, below the synapse, at the level of the spinal cord, affecting the peripheral nervous system causes a lower motor neuron lesion, and anything in the brain or the spinal cord above the spinal cord level causes an upper motor neuron lesion. Now let's look at an MRCP question. This is from MRCP Updates. So a 30-year-old woman presents with progressive weakness of both lower limbs and a sensory level at T10. She can't mobilize, has been admitted to hospital, finding it difficult to pass urine. Past medical history includes an acute episode of visual loss. So we've got weakness and visual loss, which affected her left eye and took several weeks to resolve and occurred some 6 months ago. Refused medical intervention at that time. She smokes 15 cigarettes a day. Examination shows bilateral weakness of the lower limbs with increased tone and hyperreflexia. So hyperreflexia, hypertonia, this is upper motor neuron lesion, right? We have a look at the blood. CRP is a bit elevated, but otherwise lymphocytes are a bit high and proteins a bit high. Okay. Before we discuss the question and the images, I'll just shortly mention MRCP Updates. The question shown here is from MRCP Updates Question Bank. If you are preparing for MRCP Part 1 or Part 2, subscribe using the link below and you'll get a 10% exclusive discount. There are thousands of MRCP past paper questions with elaborate explanations and an online textbook ideal for visual learners. I personally used MRCP Updates for my Part 1 and Part 2 preparation. It's a great preparation resource and I do recommend using it 3 to 6 months before your exam. If you're unsure how to start your preparation, I'll put 2 videos on the screen at the end of the video detailing what to do to prepare for your MRCP Part 1 and 2. So let's get back to the video. So again, let's see how we can eliminate the answers just by going on our categorization as we mentioned earlier. So first question is this upper motor neuron or lower motor neuron? It's upper motor neuron because there's hypertonia and hyperreflexia. So Guillain-Barré syndrome is a cause of lower motor neuron lesions, so we can eliminate GBS. Now let's have a brief look at the MRI image as well. We see one round lesion around T10 in the spinal cord. Now we don't see any destructive lesions in the spinal cord or any other significant abnormalities. So the second thing is to categorize whether it was acute, subacute, or chronic. Now it's a progressive weakness that's been going on for weeks. So this is a subacute cause. Now this again eliminates choice A because a spinal artery infarction is going to be acute within hours to days. Again, a transverse myelitis is also excluded because they're also acute. So A, B, and E are excluded. We're left with multiple sclerosis and spinal tuberculosis. Now it's causing visual symptoms. So you've got visual symptoms and an upper motor neuron lesion like weakness, which is suggestive of a demyelinating condition such as multiple sclerosis. So I would go with choice C. Other indicators against a spinal TB is lymphocytes are not raised enough and you don't see any destructive lesions in the bone, which you would expect in a spinal tuberculosis. And you see a very distinct round lesion that you expect in multiple sclerosis. Okay. So that's that. If you enjoyed the content, please like the video and subscribe to the channel. On the screen, you will see two videos. One for MRCP Part 1 preparation, or for MRCP Part 2 preparation. And on the other side, you'll see a more detailed video about how to localize a lesion and a detailed explanation of spinal tracts. All right, I'll see you next time.